Okay, just to finish up the last few slides. Again, collaborative care here with Cushing's depends on um, getting if it's Cushing's syndrome and it develops because of the use of corticosteroids, often those will be gradually discontinued, and you can't obviously take people off of those steroids rapidly because they get rebound inflammation and problems that make their underlying disease significantly worse. So you have to gradually, it's where you see people taper off prednisone therapy very slowly, or go from a higher dose and decrease them slowly down to a lower dose, and then maybe they won't have as many of the symptoms of Cushing's syndrome. And in some cases, they'll convert to an alternate day regimen, like one day they take one dose, another day they take another dose. And again, gradually tapering these down avoids potentially life-threatening adrenal insufficiency issues. Surgical interventions are much like we've already talked about. Pituitary or adrenal tumors can be removed. We've already discussed the hypophysectomy and the transsphenoidal approach. They can do it through a craniotomy method as well. And for the adrenalectomy, usually they will just do unilateral. If they find that one adrenal gland is the problem, then they'll just take care of taking that one out. If indeed they definitely have to have both adrenal glands removed as part of the surgical intervention, then they will require lifelong hormone replacement. And they will almost flip to being more like an Addison's patient, where they have to have support because they now have no adrenal glands producing anything. And so, again, post-operative, what are you watching for? If the adrenal glands have been removed, or if the pituitary gland has been removed and is now not producing the ACTH to stimulate the adrenal glands, then you're going to see the patient, drop off on this over production of glucocorticoids, but they may swing too far the other way to where they're almost having Addison's symptoms. Again, for Cushing's syndrome, you want to have preoperative care, control the hypertension and the hyperglycemia. If they develop hypokalemia, that's got to be corrected so they get more potassium replaced. Might be on potassium supplements. And then usually they will have an NG tube for a period of time, a Foley IV. They may be on central venous pressure monitoring, just because of how this can, throw the system in arrears with the hemodynamic monitoring between hypervolemia and hypovolemia. And then these patients are at a risk for hemorrhage, as most surgical cases are, so you're watching for that, particularly when you're removing glands that are in the head, just like we've talked about, some of the mental status changes if it was pituitary. And then also related to, manipulation of any of these glandular tissues can make a very unstable hormonal environment where you're really having to watch all the fluid balance, blood pressure, electrolyte levels just very frequently. Often patients are going to have to be on high doses of IV corticosteroids during and several days after the surgery because of the stress of surgery, and they've now had the adrenal glands removed that were producing a high level, so you're trying to gradually kind of deal with the stress of that and bring them down slowly versus an abrupt stop of they're high dose steroid production, and then suddenly they're zero after the glands are removed. And again, these are just typical. Circulatory instability is the main thing that you're really watching. They may get AM urine cortisols just to kind of see how the levels are in the body as well. All right.